Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today we're going over regional anesthesia. Or actually, we're re-recording the regional anesthesia podcast. The last podcast, the audio was horrible, and so John and Rick helped me out, and we are re-recording this podcast. So what I'd like to start off with is kind of a recap from our analgesia and sedation podcast in CPG on the priorities of analgesia. So the first priority being keep the patient alive. Second priority is don't do anything that's going to degrade their physiology. Third, treat their pain first. Fourth, patient safety, so your sedation. And then fifth is taking away awareness. By following these priorities of care, that's when you know when to apply analgesia and sedation in a safe way. So John and Rick, how does regional anesthesia fit into the priorities of analgesia?
So it's just another tool in the toolbox. What it allows us to do is we can help control someone's pain without necessarily taking away their consciousness, their respiratory drive. It cuts back on the use of narcotics or like ketamine, something that would actually take their awareness away and would require more nursing care. If we keep them conscious but control their pain, they can better take care of themselves and they need less ancillary care.
Yeah, so like we're saying, basically we're looking at a time where you're not obviously on the X, but you're going to be wherever you're at for a longer period of time. So your prolonged field care scenario is a great option for this. Other types of evac is another good option where you're going to go for 6 hours-ish without having options to continue to control their respirations or their other factors that you need to worry about when you're on MAC or other types of anesthesia.
Okay, so how do you decide when to use a regional block versus some kind of parenteral medications?
So again, just like any other tools, it's going to kind of depend on the situation. So I'm going to look at how much equipment I have, how much time I have, and what my problem sets in the near future are going to be, not only for this patient, but for possible upcoming patients. So for me, ketamine is definitely the wonder drug, and we've all, I think, across the board agreed that. But with that, that means there are certain places that I want to be able to always be able to use a wonder drug. There are other places where, why waste that if I don't have to? So if I'm going to be in a prolonged field care or evacuation situation, I want to minimize how much ketamine I'm using on that patient so that I can use it on the guys that are on the X. So that's going to be one of my decision points.
So basically, I mean, doing some regional anesthesia is pretty quick and easy. It's pretty simple. So I look at it as how complicated is the wound? How extreme? Is there a fracture involved? Is it deep tissue? Is it just superficial? If it's superficial, a regional or a local is just fine. However, the other thing is time. Doing regional takes more time. You have to take your time, measure your landmarks, get the right locations. If you're using ultrasound guided, it takes a certain amount of skill. If you're doing stimiplex, again, it takes a different skill set. But you have to plan this out, and this is something it's going to take a little bit of time. It's not going to be quick. So it's a deliberate act that you have to plan out and conduct. So this patient probably initially got some sort of IVIM pain management, and now what you're wanting to do is either because you have to sit on him or he's got a long evac coming up and you don't want him to have that potential, that respiratory compromise. You want to raise his level of consciousness and let whatever IM, IV, pain medications he was given start to wear off. And then you might consider a regional and to control that pain as he comes out of that. So that's kind of how I look at it. If I can do a local, that's pretty quick and easy. And maybe I'll do that initially until I can get the regional set up, depending on the extent of the wound.
Okay. So you mentioned him starting to come light, I guess, is a good way to say it. Every patient's going to be different, but the principles are going to be the same. So what do you use as an indicator to say he is light enough that I can give him a regional block without pushing him over?
Okay, so that's an interesting question, because what I look at is, one, the first sign that he's coming light is usually increased respiration. So his respiration will increase, his heart rate will then increase. As his body, he may not have broken the threshold where he's conscious, but his body is feeling the pain. So his respirations and his heart rate will start coming up. So at that point, I kind of look at, hopefully I've got everything planned out and laid out, and I can start doing my regional anesthesia. One of the things we look out for, a caution, is that if he's received especially opiates, you can get that kind of crash when you take that pain stimulus away. So we have to be careful. We try and do it at about the right time. That's a technique when the respirations pulse rates start elevating, is to go ahead and do that regional. And then the other thing is have your reversal agents on hand just in case. So be prepared for that contingency.
Okay. I mean, in the vital signs that them starting to peak, I mean, that definitely makes sense. But considering this patient also has some kind of trauma, physiology, or illness, I guess, but something is wrong with his physiology already. How do you use any kind of scales for like level of consciousness, or you just strictly go by vital signs trending?
Yeah, so a lot of times you're going to use like a RAS scale, and I know that you went over that in the last podcast. So basically you're looking for a RAS scale of about 1 on that patient, which is oftentimes equal to a pain scale of about 4. Obviously these are rough estimates.
4 out of 10,
but
just ballpark, and it's going to depend patient to patient and whatnot. I mean, many of us have kind of experienced something similar to this, or this in specific. I had a buddy of mine on a halo train up, dislocated his ankle, and I gave him a lot of morphine back in the day. We carried morphine, and I know it's fallen out of favor, but we had a protracted evacuation. It was pretty bumpy, pretty painful, a lot of stimulus, a lot of pain. So I gave him a lot of morphine, and he was fine until we got to the hospital and they set the joint. And then his eyes glazed over, and he looks over and says, "Rick, I love you, man." And then he passed out. So and then I got to stay with him the rest of the night, make sure he kept breathing and so on. So those are the things we kind of plan for, and plan those contingencies, and try and prevent if we can, and treat if we must.
But what about after your 6 hours, the pain is starting to come back? Would you be willing to do another block, or would you switch over to another drug?
Well, no, I would definitely I would consider another block depending on time.
Right.
How much time do I have? Now, I've already measured my anatomy. The markings are already there. Now I'm going to have to go back in and find the nerve again, and I got it. However, at the end of the metabolization cycle for that drug, I may look at decreasing dose, because I don't know how fast he's metabolized, that is a range, and I want to play it safe. So I may decrease the dose. I'm going to keep the volume the same. I may decrease the dose on a subsequent nerve block, but I would definitely consider it.
Would you say ballpark 50%?
Yeah.
Yeah, and I think it's a good bracket to start with, is 50%. And then if you learn later that you need to up it next time or whatever, then you can try to wean that off back and forth. But that's a good bracket, and it's a great point. And that's why we talk about maybe not going max dose round one. Trying to stay away from that. It gives you options.
Right. And if you're using ultrasound, you probably won't have to go max dose.
Correct.
Exactly.
Correct.
The more accurate you are, right? So when you're going max dose, first of all, you shouldn't. But if you choose to, it should be because you've got pretty much no adjuncts to help you out.
Now, when I talked about 35 to 45 cc's for the sciatic block, that is using the Stimiplex. That is not the ultrasound dose. The ultrasound dose, you're correct, it is much less. I don't remember what it is off the top of my head. That's why we have references. This is a planned event. And
no, but I believe, like, dosing-wise, you're just looking to see that whatever agent you're using surrounding the nerve sheath, whatever volume that is in a location, once you see it surround the sheath, then you've gotten a block.
Yes.
And you'll know right away. That's the other thing I love about regional anesthesia, is there's really no question. Right? So you're going to, especially if you're using a Stimiplex, but either way, you're going in there and you'll see the muscle move a little bit. You'll see it, and then all of a sudden, as soon as you inject and you know you're in the right spot, instantly those nerves stop firing. There's no question. Yep, I'm in, and it worked. I've got a positive block. So if you find yourself guessing, it's probably because you don't have a good block.
Yeah, your location's off.
So, and that's why your dose goes up. It's because they expect you to miss a little bit.
Right. So you're just using the larger volumes to kind of CYA.
Yep. P for plenty isn't always just for demo.
Right.
Thanks, Charlie.
Right. So, regional anesthesia, it's very, it's pretty safe, but nothing in life is free. What are some risks that go along with this?
So, you're going to look at, obviously, one of the major risks is local anesthesia systemic toxicity, right? So LAST syndrome. And that, the real danger with that, and the reason that's the number one I bring up, is that unless you're carrying the lipids that you need to take care of that, which the likelihood is very low that you're going to do that. It's a couple grand a bag. You're looking at 2 bags per patient that you're going to need. Then you're just literally going to have to watch your patient seize to death. So, not saying that don't ever do this and don't get too scared and walk away from regional anesthesia. Just recognize there is a relatively low risk, but high problem set if you do this.
And the other thing is it's relatively dose related. So by decreasing your dose, by staying within the recommended total dose for the patient, you can minimize the chance of this happening. And I mean, we teach our students that to calc out the max dose for your patient. That's the first thing you do, and then you're going to total up how much agent you need for all the blocks because it's cumulative. And then if some of the blocks are pretty healthy doses, when you look at a sciatic block, 35 to 45 cc's, that's huge. And so that may be at or exceeding your max dose for the patient just in that one block. And if you're going to do a femoral also, so what we teach is volume is more important than concentration. So you make sure you stay below your max dose for that patient cumulatively, and you buffer the rest with normal saline. So you may have an injection that, like the sciatic, where you put 20 cc's of agent and 20 cc's of normal saline, and that's what you're going to use for your block to allow you enough to do the femoral and hopefully knock out the whole leg. The other is to look at what happens if you have a failed block and you're at your max dose. So those are things to consider. Now, you can't really adjust from that. So that's one of the issues that we have. When you talk about complications, there are several others. So if you end up with the agent being injected somehow IV or through a vessel, IV or whatnot, accidentally, that's why we aspirate. But still, things happen. You can get cardiac toxicity. So you have the cardiac effects. So if you should have your patient on a monitor so you can recognize this and take appropriate actions. The another is you don't inject directly into the nerve sheath. The nerve sheath does not expand, so you'll actually damage the nerve by doing that. So with the stimiplex, that's why we adjust the voltage. If the nerve bundle, the target nerve bundle, is firing at 0.3 megahertz, then you got to pull back a little bit because you're too close. You may be in the nerve sheath, but with the ultrasound, you can
see it.
You can see it. You can see the tip of the needle, and you see it that it's not in there. You can make sure it's right beside, and when you inject, you can actually see the fluid surrounding the target nerve, and that's a pretty good indicator that you're effective.
So you mentioned volume is more important than concentration. That sounds a little bit counterintuitive. So I guess what exactly do you mean?
So with that, what you're doing is the way that the lidocaine is working is by making that buffer space between the neurons. Right. So the normal saline will do similar, just not as effective, not as strong. So you're just making a wider gap between those neurons firing.
So basically the saline, just with normal saline, getting it in the right spot, putting that pressure on there, you can get a nerve block. It's just not going to last. It's going to dissipate because it's normal saline. The agent in there chemically disrupts the neurotransmission, and that's what we're going for. So even diluted, it's still going to do that. Now, granted, diluted, it may not last as long. You may not get the 6 to 8 hours or whatever, depending on the agent. You may get a little bit less. So you have to plan accordingly. And if you're monitoring your patient, you should be able to, he'll tell you when his pain starts increasing, and then you can kind of get a feel for when you need to redose.
And if it helps to get your mind around it, if you think about it, when you purchase lidocaine or look to choose yours, it's already technically a lot of times doing that for you. You got 1%, you got 2%. That's telling you the concentration. So all you're doing is going ahead and going, hey, I've got 2%, let me make it, 4% or the vice versa, right? 1%.
0.25% or whatever. Yeah.
You're switching that up. That's really all you're doing, decreasing that percentage. So with that, I will also say we talked a little bit about ultrasound and about stimiplex usage. So we talked to a good friend of ours, Peter Fry. He's a CRNA. He also helped start the regional anesthesia program at Fort Bliss. So he's pretty smart on this, definitely a lot smarter than I am. And he said that all the studies they showed that it doesn't help you to put the two of them together. So a lot of people say that you'll hear people say the gold standard is both ultrasound and a stimiplex identifying at the same time. There's no knowledge that we've been able to find with Pete that shows that's actually the case. You do one or the other. Ultrasound is obviously better, but it doesn't help or hurt if you use it.
So I know we're looking to transition more towards ultrasound. The stimiplex is great, and it's an inexpensive device, and it's in the process of being fielded to the new tax sets and so forth. However, it's got its limitations. I mean, as one CRNA put it, can you imagine the guy that held onto the grenade, blew his hand off, and used the stimiplex to stimulate those muscles to find out if you're at the right nerve, and stimulating those muscles where that injury is? That's not cool, man. So that's causing a lot of pain before you deaden that. So in that case, ultrasound guide might be a better choice. But yeah, at the end of the day, you do what you got to do to take care of your patient.
What about other risks such as like unrecognized compartment syndrome? How would you get around that?
So once you deaden those nerves, you're going to take away the sensation. So if the patient develops a compartment syndrome in that regionally anesthetized limb, he's not going to know it. And so there's two things you need to do. One is look at the mechanism of injury closely, and then monitor your patient. Distal pulses, cap refill, put a pulse ox on a toe. There are different ways of monitoring that. The other thing is if the wound is significant enough, there's nothing wrong with planning and conducting, doing a bedside fasciotomy to relieve that prophylactically.
Yep. And Convenient Lead's already got his block on, so you can do it pain-free and do it right there.
You can just sedate him for a while you do the procedure so he doesn't freak out because you're rooting around in his leg, and make sure you get all 4 compartments for the lower leg. That's key. And but yes, doing a prophylactic fasciotomy if the wound is significant enough, mechanism of injury indicates, and if not, if you don't think he's going to develop a compartment syndrome, still monitor just in case.
Okay. I've been reading, at least with things like epidurals or large regional blocks, there's a potential for vasodilation and hypotension. For the regional blocks that we would do, if they're full legs, I guess would probably be the biggest area. Is that a risk that we need to be prepared for?
It's always going to be a risk, but it's pretty low in these kind of cases. So a lot of the epidurals and other things like that are catheter-run regional anesthesia. And that was one thing I'll also say that Peter was pretty clear on, and I definitely agree with him. Like, we are not in the skill set that we should be looking at catheter-run regional anesthesia. There's a lot of complications that'll cause from that. One of which that I wouldn't even thought about, but if there's a even minor tear in a vessel somewhere, over time it builds up and through osmosis will go through and you're going to cause all kinds of problems that way. So, well, that's a long answer to say no. It's not a very high likelihood.
And for those who may be wondering what we're talking about, catheter anesthesia. So when you're doing a regional, you can put an indwelling catheter and have a pump where it's timed every so often. It's going to give a certain dose to that nerve cluster. So you know where you put that needle, you're going to leave an indwelling catheter there so that you can continuously keep that nerve anesthetized, and that can cut back on your dosage and whatnot. However, it's going to be a protracted. It's what they do in the hospital for prolonged periods of time, and the skill set it takes for that, we don't have it, and I don't see how we could teach it and maintain it. So I don't know if the juice is worth the squeeze on that one. Somebody much smarter and with rank on their collar, they'll decide that.
So if I want to include this in my skill set, yes, I've been trained at it through the schoolhouse, but it's been a while, and I don't feel comfortable doing it myself. Where can I go to get more training on this?
Well, step one, I would say, I'll go ahead and plug it real quick, is come on down to the Special Forces Medical Sergeant Skills Sustainment course. You'll get a little bit of refresh there, actually a pretty reasonable amount. So that's one way. The immediate way is to get with your battalion doc. A lot of times they can help you out or get you connected to some people at the hospital that'll let you get some experience there. But then there's also skill sets that are involved in this that you don't necessarily have to use regional anesthesia to do. So ultrasound skill set. I encourage everybody to be continuously trying to seek out chances to up that anatomy and physiology understanding and knowledge. that's easy to increase. And then the hardest part from most people I've talked to with this, when it comes to ultrasound, is keeping the needle in the field of view while using it. So that's where blue phantoms and your ultrasound there at the school, or not the schoolhouse, but actually at your station works out. From talking to Rick, I understand that there should pretty much guaranteed be at least one ultrasound per every other ODA across the force. If you're one of those ODAs that's like, what? I've never heard of that. There's no way. Go to your battalion doc, start rooting around it. But I guarantee you're going to start finding there's more out there than you knew. So those are your main skill sets and ways to do it. There's also, and I need to do some research on it, but Pete mentioned a lot of homemade recipe style of how to make your own blue phantom. So that's another cost-effective way to train that.
So the other thing is have references. I mean, we don't expect guys to remember everything about this. And if you've got a couple of good references you can look at, has pictures, and it details how to measure out your landmarks, and it's going to be a lot safer. Like I said, when you're doing this is a planned event. This is not, I need to do this stat. This is, okay, I have made a decision. The timelines are significant enough that the patient's going to benefit from this, so I need to plan and do this. So look at your references. I mean, the standard military one's the MARA. It's the Military Advanced Regional Anesthesia and Analgesia Handbook, and it's a free download. So you can, what's the website? Is that?
You can, I'm pretty sure pfc.org has it. And then I know that we're going to be putting it up on SOMC, so your Special Operations Medic collaboration, if you want to look them up. And then the other website or company out there that's got a lot of good information is going to be NYSORA, your New York School of Regional Anesthesia. They're a great option.
Yeah, that is a fantastic book, too.
Yeah, so if you're poor like I am, I'd advise going on Amazon and finding a used book. I bought mine for $9 versus the original $380 ticket price that I could not afford, or at least didn't choose to. But they also have a lot of good pieces of information just on their website. So their website will give you a lot of decent videos. They'll give you a nice, almost like a CPG-like format, so you can do that. And
what was that app that Courtney has?
That's a good question. I don't know off the top of my head. I know he talked about it just recently, so we might just add that to the notes here if we don't think of it, because my TBI brain is kicking in. But either way, so there's a lot of good options to kind of do some research and get some information out there.
Yeah, it was like Block Buddy or something.
Yeah.
But those are my advised means of doing it. I think what else training-wise you can do. But honestly, so I would still want to cover, like we've talked about some scary stuff on this, and I've noticed a lot of guys are kind of reluctant to do some of this in the field because it's new and scary. But I want to emphasize as much as I can the massive amount of benefit that this can provide us. So, one, it drastically reduces the amount of pain management I have to do and pain meds that I have to carry, right? But two, it frees me up, not completely, but a reasonable amount, to start paying attention to other patients, start paying attention to other things. And I can communicate with my patient, which is huge. So we talk about monitoring all the time and all these cool new things, the Emma, the Tempest, you name it, right? But nothing is better than communication with your actual patient. And the benefit of regional anesthesia is I can keep him at a monitorable rate of communication, where I can wake him up a little bit, talk to him, know what's going on, which helps him. It helps PTSD issues later. It helps with phantom limb pain later, and it helps me work easier. And as Rick says all the time, and I agree on the same way, I'm a lazy medic. So if it's going to be something I work hard now, so that I have to work less later and less repeatedly, I'm in. And I think that's kind of what regional anesthesia brings.
Yeah, I think it just brings a very good level of analgesia over a long period of time that you're not having to redose every 30 minutes or 20 minutes like we would with ketamine bumps. You can continually talk to your patient. He doesn't need those heavy doses of ketamine or fentanyl or morphine or whatever you decided to use. And you can save those drugs for someone who needs them right now, or potentially later when your block does wear off.
Yep, exactly. And it allows for evac, I think, a lot of times, too, is nice. So we've talked a lot about PFC and the idea that we're sitting with that patient the whole time. But there's that other piece that I know you recently did a podcast on as well, that talks about evac issues. And I'm not always going to be there when it evacs. And maybe somebody who's not skilled is going to be there. So if I can reduce that problem set on them.
Yeah, if he can guard his own airway and we can control his pain for 6 to 8 hours, and that's the time of the evac or whatnot, then I think we've increased his chance of a positive outcome on the backside. And that's what our job is.
Cool. Do you guys have anything else you want to add?
No, I think that's pretty much it. I'll say again, like, go out there and research. So, Nysora, great option. Mara, fantastic free option. Come to the SF Medical refresher course instead of just talking with Steve. Plus, it's mandatory, so it helps get us some students there. And look out there, and there's a lot of people doing some good research. So, go out there and find some other people out there.
Yeah, I had a guy ask, why would you teach this skill set if you can't maintain it? And it is hard to maintain. It's not something that I expect any of our medics to be able to do at the drop of a hat. But I told him I don't care about sustaining it on a daily basis. What we need is a program in place to train guys up before they go down range and may need to do this. And so part of that was having an ultrasound program at your unit. But when it comes to regional, I say, make friends. Make friends with someone that does this for a living. And when you get a chance, go up there and shadow them and learn from them. Somebody that does it every day and learns some of the tricks and some of the ways of dealing with negative outcomes, the contingency plans. That's my best advice.
All right. Well, thank you guys. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.